I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome to Journal Club. Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. I'm here with Monty Mythen, Editor-in-Chief. Hello, Monty.
Hey, Desiree.
Right now, we have the opportunity to sit down with another special guest, Dr. Paul Grant. Dr. Grant is hospitalist at the University of Michigan. He's the director of perioperative and consultant medicine there. So, Paul, thank you so much for sitting down with us.
My pleasure. Absolutely. Thank you for having me.
Monty, do you want to start off asking a couple questions?
Well, we already covered off in one of our teasers the paper by Gupta K. et al. BMJ opened December 2018, which was a meta-analysis, I think, of opioid respiratory depression risks. And
yes,
the incidence was about 0.5%, and the risk factors, if I got it right, were cardiac disease, pulmonary disease, obstructive sleep apnea, and a high dose of opioids.
Correct.
So any other big takeaways from that? I kind of thought, the OSA thing is still a bit controversial. Perhaps we're not surprised by the cardiac and pulmonary. Not very common, I thought. It was a bit surprising.
Yeah, agreed. I think it was some nice work to add to the literature, an area we still sort of struggle with, but of course with the focus on opioids right now, certainly nationally, I think maybe even beyond, we're looking at that as a risk factor, and we see a lot of it. With pulmonary risks just being, the more common risk factors we see perioperatively. So this was nice. It kind of confirmed what we knew, I think, about some of the things that would cause risks, or at least increase the risk for opioid-induced respiratory depression, the cardiac disease and pulmonary disease. But sleep apnea, I think a lot of us suspected that's a risk factor, but it's one of those things that's kind of hard to know. I think a lot of patients have it but don't know it, so it becomes a little bit challenging. In this particular meta-analysis, these patients were officially diagnosed with sleep apnea. It was pulled out as a patient risk factor and was significant, as increasing the risk for that. Diabetes, kidney disease was not found to be significant, which is maybe not as surprising. But with respect to the other factors, it was the morphine equivalent daily dosing that was also significant, but not PCA or epidural, analgesia.
So the dose of the opioids is something I think we all agree perhaps we could do something about, combined with perhaps monitoring more closely some of those other patients?
I think that was the take-home in a sense. So what do you do with this? Well, kind of knowing these risk factors, maybe these are the patients that we really need to look at in advance and say, wait a minute, we have a patient coming in, they have pulmonary disease, they have cardiac disease, they have sleep apnea, they're on a significant amount of opioids, going into surgery.
Yeah.
We need to watch this patient intraoperatively, immediately postoperatively, and then even until discharge.
Because back in the day, I mainly do critical care. Now I mainly do surgical critical care. And way back, there used to be high dependency unit requests for admissions for patients who were now on a lot of morphine. We seem to have kind of got to a point whereby we're kind of relaxed a bit more about that, and they go back to the floor and you say, you want me to admit someone because they're on a high dose of morphine now? Is that... Do we need to rethink that one?
Well, I wonder if that's true, just because the incidence of opioid use has become so commonplace.
I was just to say it's like second nature.
Right. I mean, that would be, we wouldn't have enough ICU beds to kind of manage that patient population, I think. But the increased monitoring is something that most hospitals are looking at. What do we do? Continuous pulse ox monitoring is a minimum now at many places.
You can do it remotely. If I kind of jump you forward to the area where there's perhaps more ongoing controversy. I think you presented to us 3 papers, we'll put them in the show notes, about HbA1c and that as a risk marker and perhaps a modifiable factor, and then about glycemic control.
Yes.
And where do we stand?
Yeah,
I thought I had this one sorted out.
Yeah, no, it's great, and it's interesting because I think people jumped on this potentially a little bit too soon. So I think what we're seeing now in the data is the hemoglobin A1c is probably not the most important thing to look at in terms of making sure that looks good before moving into surgery as a way to try and reduce, perioperative complications. Surgical site infection's a big one. Whereas there was some hint of data or some data that's suggestive of that, and observational data, and I think it's just something we think, well, that's a lab I can get, and I know I can move it. If it's elective surgery, I have time to move it. Let's use that. And I think, sort of the cat was out of the bag in a sense as we're sort of accumulating more data on this, because a lot of places around the country have already instituted a cutoff hemoglobin A1c before their elective surgery. I think the elective joint arthroplasty has been the big one there. But what we're seeing now is the A1c is probably not really the best marker. It seems to be maybe kind of poorly predictive, actually, of perioperative risks. What tends to be more indicative would be the actual perioperative glucose itself. itself.
Yeah.
So that, glycemic control in the immediate perioperative setting. What are they immediately pre-op, intra-op, and during the hospitalization, maybe for the 3 days after surgery, or maybe the entire hospitalization. But really, what are those blood sugars? And if you can control that in that short period, then you might be looking at a better way to reduce the risk of some of these complications, such as surgical site infection.
Yeah.
I mean, one of the very large observational studies which came out of Duke, I think it's a trawl sounds like an ugly word. Their EMR, which goes back to 1999, a huge cohort of patients, cardiac and non-cardiac patients. Now, the non-cardiac patients, if I was listening right, there was an inverse relationship. So,
with the A1C.
Yeah. What's that?
This was a large cohort of patients, single institution, but correct. It actually showed that a lower A1C had a higher incidence of mortality. Mortality was their only endpoint in this particular study. Tens of thousands of patients. That didn't make sense. What the author sort of thought was maybe it was these patients that received the most aggressive care because they had the ones that had terrible A1Cs. They got aggressive care in the intraoperative, immediate operative sort of setting, and maybe that's why that showed the way it did. That their mortality actually seemed like it was better, having a higher A1C in that case. Again, the A1C predicting weeks to months prior to the surgery. What this really showed when they looked at that same non-cardiac population. Non-cardiac surgery population was the glycemic control, though, was significantly worse. Mortality was higher for those who had the higher incidence of poor glycemic control.
We'll put it in the show notes, but I think it's Van Den Boom, W. et al., Diabetes Care, April 2018. We'll put the full quote in. For the cardiac patients, there was a U-shaped relationship for the glucose control.
Exactly, that was exactly, and that was very clear as the graph demonstrated. So basically showing having quite a low blood sugar level was increasing risk of mortality. Having a very high blood sugar level, same thing, high risk of mortality. So really there's that sweet spot there in the middle, the bottom of the U in that U-shaped curve
140
was really in the 140 range, was really the lowest incidence of postoperative mortality and where you want to be.
So, pending further evidence from large prospective randomized controlled trials, intraoperative glycemic control, not tight glycemic control, but glycemic control remains a rational approach to this challenge.
Correct. And I would say intraoperative, maybe even a little more perioperative with respect to, the post-op day 1, 2, for example. I don't think we have an exact period, but intra-op and give or take 2 or 3 days.
What's your upper limit tolerance for...
Good question.
When do you say, ooh?
Yeah, well, because as a hospitalist, I'm seeing a lot of non-surgical patients, and there we seem to be a little more lax in some ways. You mentioned this earlier, the low glycemic patients are the highest risk, really, for immediate complications and serious complications. So I think we're really looking in that, 120 to 140, maybe even 160 range is probably the sweet spot for these patients.
Yeah. So when it starts to get sort of resident ugly, do something about it. Does that translate?
That sounds about right. Yeah. That sounds about right.
and the last one we highlighted, we're going to have to break in a second because we've got to go and do some breakout sessions.
Yes.
Was the Frailty score paper takeaway, McIsaac D. et al., was the clinical frailty scale was equivalent to the modified Freed index, which I didn't know about, but I know the clinical frailty scale. But the advantage of the CFS, as you said, it was easier and it was quicker.
Quicker to do. I think the average time was 45 seconds or something like that. Whereas over 5 minutes to do the other instrument. Both were moderate for sensitivity and specificity for predicting frailty that would lead to either death or permanent disability. But I think it just highlighted an area that we're really trying to do more of in preoperative medicine, and we really should be looking at frailty for these patients. We often focus on the cardiac risk and pulmonary risk, which are important, but I think frailty is something that we need to start really shifting some focus to.
Are you recording it routinely now, or starting to?
I'm a little bit guilty of not doing something structured formally in my assessments. I'm in my pre-op clinic at University of Michigan, but it is something that's on the list of things to sort of do in a more systematic way.
I think a lot of people would say that.
Right. It's hard. You kind of know it when you see it, you think, but until you do these things more objectively, I think that's when you're really going to see, wait a minute, this patient might seem like they're low risk from a cardiac standpoint, but they are actually frail, and we know that is a high risk for bad outcomes.
Yeah. All right, well,
we've got to wrap, but one quick comment. Post-operative troponin rises. That was that big last session and the wrists, etc.
Yeah.
Clear. Unclear, work in progress.
No comment.
I'm confused at a much higher level than I've ever been confused before.
Clear as mud. Yeah.
Really interesting.
It's very interesting, and that's why I love coming to this summit. I can listen to people like PJ Devereaux and like Lee Fleischer talk about these things. I mean, the data seems to be moving to a point where biomarkers probably should be implemented, at least in some patients. The higher risk patients particularly. I think the criticism has been, well, what do I do with that? If it's a high troponin, I know that's bad for the patient, but I don't know what to do with that information. But I think Dr. Devereaux says, well, I mean, we should be managing that patient very carefully, making sure they're on an aspirin, making sure they're on a statin, watch good blood pressure control. So, the managed results or trial came up. Is anticoagulation the answer? I mean, that was one trial, which did have some limitations, but seemed to show a benefit in patient with the MINs. You do
daily troponins in every patient postoperatively?
Every patient, absolutely not. Yeah. And in fact, I'm pretty much only doing it in patients who have some concerning symptoms, but that's not what MINs is. This is high-risk patients without symptoms, considering getting that troponin. And I suspect I might need to consider doing that in some of my more high-risk patients, given where I'm seeing the evidence move.
Yeah. All right. Well, Paul, thank you so much for sitting down with us. Hopefully we'll get another opportunity. We can maybe dive into frailty a little bit more and some of this other stuff. But look forward to the rest of the meeting, and thank you for all your hard work. You can see it's paid off. So
my pleasure. Thank you so much for having me. Thank
absolutely.
Thank you very much. Absolutely.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram, or we can even gawp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find Top Med Talk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on Top Med Talk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out ebpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EBPOM meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So EBPOM, ebpom.org/meetings. Get yourself on there, and why not check out the Dallas Masters course, a Perioperative Care Practicum. Hopefully I'll see you there.